What do we know for sure in Ontario? Well, as I mentioned, the third leading cause of accidental death, and the rate has likely gone up since then. From the chief coroner at an inquest in Ontario, he suggested that 6 years ago, the number of opioid-related deaths were equal to the number of drivers killed in motor vehicle collisions. And we know that prescription opioids are killing people who are using as prescribed and using via the black market. I've talked about the absence of data. It's scandalous at best, I suggest. We know that 50,000 Ontarians are addicted to opioids. We know many more are what we call opioid dependent. We know that the cost of not treating someone for an opioid addiction conservatively costs about $44,000 per year per citizen. It doesn't take long for those numbers to add up and realize that maybe there's a smarter approach that is well, it's fiscally responsible for sure, but certainly makes a better contribution to health and safety. We also know, I noted there's an absence of strategies to address overdoses via naloxone at any level, but some good news in Ontario through the last year. The Ontario Ministry of Health has made naloxone available. The uptake has been slower than maybe we'd hoped. I think what the feeling is that local communities need some support to get that going. Naloxone in Ontario and in Canada is really dependent on having a willing prescriber, and I mentioned at the outset that the role of stereotypes and discrimination and bias, judgment, it happens inside primary care and it happens outside of primary care. At a national level, we have an anti-drug strategy. It specifically excludes prescription medications. It specifically excludes harm reduction. There was no bed of roses under the previous government. The bulk of the funds then and still do flow towards supply interdiction, enforcement, and justice. And I think it should be clear to most Canadians by now that there are, to go off a phrase from the 60s, no adults in charge. I'm going to skip through this slide, but, well, no, I'm not. I'm going to go back to this slide. This is early data. It goes to 2011. It doesn't make a distinction between suicide attempts, that's intentional death by overdose. It doesn't make a distinction between that and accidental overdoses, but it does give you a bit of a view on what the trend lines may be. They're subject to some revisions for sure in the 2010, 2011, but you can see oxycodone went up, 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 and slight decline is being reported. Like I say, the final numbers aren't in. Fentanyl is taking a strong ride up, and so is methadone, curiously enough. This is from a seminal 2009 study done in the Canadian Medical Association Journal. I don't want to talk too much about it, but we're thrilled to have Irfan Dalia on this webinar series. He'll probably go into more detail about it. But what we know, no surprise, is the prescriptions of oxycodone increased exponentially, that there was a concurrent rise in overdose fatalities, and that the use of healthcare services in the month before death was very common. About 66% had seen a physician, just over half had seen a pharmacist. Those are critical prevention opportunities. I wonder if pharmacists and physicians had that discussion in any detail about risk factors for preventing an overdose, or suggested naloxone as a viable alternative for a witness to an overdose. I suspect not. Which is why some of the stuff coming out of the U.S. is fairly exciting. This group, Andrew will be with us later this week talking about this group, Physicians for Responsible Prescribing. This is sort of their mandate at the front end, but it's important for a whole bunch of reasons, but it shows that doctors can mobilize with others in primary care to affect change. And they petitioned the FDA to have a discussion about opioid prescribing. Those discussions were happening in January, and they're ongoing. And down at the bottom left there, you see that's an American version of a multi-dose naloxone, but there is some discussion at the FDA about making naloxone an over-the-counter medication. The president of the National Institute of Drug Abuse, Dr. Nora Volkov, certainly supports that. So that would mean you could walk into a pharmacy and pick up naloxone if you thought you might be in a position where you would witness an accidental overdose. Again, for perhaps someone in your family or a significant other or a friend, whether they're using as prescribed or using illicitly, the body doesn't really care, of course, whether it's legal or illegal. But those are some of the discussions that are happening in the U.S. Those are the discussions that so far have been largely absent in Canada, notwithstanding the decision from Health Canada to approve generic versions of OxyContin in November of last year. Interesting situation. We had a full provincial and territorial support to urging Health Canada not to approve a generic version, and the Health Minister did approve them. She's approved 6 so far. Around the same time, out of the Crime Prevention Council, we released what we think is the first Canadian report on barriers to calling 911 during an overdose emergency. We surveyed 450 people who were using primarily opioids, but they're certainly using illicitly, and we surveyed them to determine if there were any barriers to calling 911. That's what the anecdotal evidence would suggest. That's what the data from U.S. and elsewhere suggests. And if you remember one thing, remember this number: 46%. At the last witness overdose, 911, which is our emergency line, was called just 46% of the time. The primary barrier identified by participants was fear of the criminal justice system. In Canada, with the exception of Vancouver, when you call 911, you would typically get all 3 first responders. You would get ambulance, you would get fire, and you would get police. And so Anthony and Kayla and I think myself will be chipping in with a webinar in more detail around what we found and potential policy options. I note that in the U.S. there's a plethora of legislation being passed at the state level called Good Samaritan legislation. It provides limited immunity all in for witnesses at an overdose, all in an effort to encourage 911 call rates. You know, when someone has a cardiac arrest, the call rates are above 90%. When it's an accidental overdose, particularly in an illicit situation, well, those call rates clearly drop. So I mentioned Good Samaritan legislation. I think about a dozen states have passed it so far. It's pending in a number of other states. We haven't begun to have that discussion in Canada really at any level. There's an emerging group, but it's really early days, and Good Samaritan legislation is on the radar there. That would be a federal type of legislation. Not sure there's an appetite in Ottawa right now, but I think it's worth exploring and worth maybe crafting a piece and presenting it to the good folks in Ottawa. And of course, overdose prevention, including naloxone, widely accepted and delivered in the U.S. Starting in 1996 with the Chicago Recovery Alliance. And yes, it's taken many years and many deaths to get to the stage where the U.S. is today, but there's more than 200 providers around the U.S. Delivering naloxone, delivering overdose prevention information. We see those groups who are bereaved parents, who are people who are active in their substance use, inside medical clinics, and so on and so forth. I note that many states are passing enabling legislation to encourage wider distribution of naloxone, including one state where co-prescribing with an opioid will be a major feature. So these 2 bullets on this slide, our committee met after the 911 report, and these are 2 recommendations coming out of our council, the Crime Prevention Council. So I hope you can kind of see how some of this stuff, even though it looks squarely in the health realm, it relates very much to crime prevention. I would like to highlight just one project. There's a number you could choose in the U.S., but it's called Project Lazarus because they show such strong results. In Wilkes County, between over a 2-year period, OD deaths went down 69%. It was a 28th straight decline in OD rates since the program started. Those are huge, huge numbers. And I think that offers a lot of potential for communities right across Canada, of course. And then concurrent with that, you see a decline in hospital visits and admissions, down 15%, whereas the rest of the state increased. So other interesting data out of North Carolina, and just off the top of my head, I think the average cost of admitting someone for an accidental overdose in North Carolina is around $17,000. The cost of a naloxone kit is about $18. It's pretty much a no-brainer. Naloxone compared to Ontario has about 3 million less people. I think they're floating around the 9 million mark, but all told, hospital visits in North Carolina total about $100 million. So again, there's a financial imperative to get serious about overdose prevention and intervention. There's the website down at the bottom. They do great work out in North Carolina. I mentioned Ontario introduced, or certainly made naloxone available to communities that have a willing prescriber. That has to be a medical doctor or a medical officer of health. And a big shout out to Kenora region, who last week became the third community in Ontario to offer naloxone to people at risk of dying in their communities. The first in Ontario was Toronto through Toronto Public Health, followed by Ottawa Public Health, and now our northern friends. In Waterloo region, good news here. We have multiple prescribers. It's a very different model actually than the health unit model. It's more of a community-based model, but we've had 5 or 6 prescribers that'll start to come on board in just a month's time. So it took a while, but here we are. Also last year, not to be outdone by Ontario, British Columbia Center for Disease Control launched their naloxone program, and they've got a fantastic website. It's called Towards the Heart. I encourage you to check it out. It's a wealth of information, very, very well put together. And again, I'm excited to have both Despina and Jane join us for an overview of their program. So finally, to sort of conclude, the emerging Canadian discussions really are focused on getting serious about monitoring data collection and dissemination of really basic health information related to overdose, death, and injury. There's some discussions about where naloxone falls on the Food and Drug Act in Canada, on the Controlled Substances Act. It's specifically excluded from Schedule 1. There's discussion about adding naloxone to provincial benefit plans. Right now, it comes out of your own pocket if you don't live in Ontario or British Columbia. So there's been a bit of a movement within Ontario to add it to the provincial benefit plans. And of course, there's some of this stuff can't be implemented off the corner of your desk on the backs of people who are already stretched in their work. That resources to help establish and support overdose prevention in communities is absolutely critical. Some discussion around reducing the barriers to 911, and then maybe some discussion about smarter prescribing, dosage, and duration. Pain management is I'm not a medical doctor, but pain management, my heart goes out to doctors when someone comes in and complains of lower back pain. But we did see a huge change in opioid prescribing for non-cancer pain that began several years ago, and we know what the outcome has been. A lot of unintended death and injury, a lot of unnecessary addiction, et cetera, et cetera. So I'm excited to hear what Irfan Dalia has to say. I'm excited to hear what Andrew from Physicians for Responsible Prescribing has to say. And if you check our website out, you'll see a neat little video on there from Dr. Mike Evans. It's hot linked in there. There's a French version and an English version, but it provides a nice overview of prescribing for patients and for doctors. All of which is to say, we believe a multi-sectoral approach with everybody at the table getting serious about opioid-related issues is an approach to that is smart on crime, that differs perhaps from tough on crime, but it's fiscally smart, and it's smart in terms of reducing the health and socioeconomic burden that are borne by all Canadians, because at the end of the day, there really is only one taxpayer. So whether we're paying at the national level or at the provincial level or at the local level, really at the end of the day, it's you, me, and your fellow Canadians across this great country. I'm going to encourage you to stay tuned to the Eyes Wide Open website, to check out the Preventing Crime website, and to consider becoming a friend of crime prevention more formally. It takes a couple of minutes, and then we'll send you all sorts of annoying emails. No, that's not true. You can follow us on Twitter at Preventing Crime, follow drug-related issues. That's where I'm tweeting out about WR Drug Strategy, and then, of course, on Facebook.